And just a reminder that when we go into breakout groups for the case study, please have your microphone and webcam on if possible. And if you have any questions during our speaker or any other time, please feel free to put it in the chat. And we will have someone monitoring the chat to answer questions. And while we are on the chat, please go ahead and put your name and your email and your professional affiliation in the chat so we can use that for attendance. And then lastly, renaming your profile. Just go ahead and click the 3 dots on your picture and you can put your name, your title, and where you work. All right, and I will pass it over to our facilitator, Rebecca Dosh Brown, whom many of you have seen before. And I don't have your bio pulled up, Rebecca, but Rebecca used to lead our LEND program, which is Leadership, Education, and Neurodevelopmental Disabilities. And now she has moved on to a different role. And Rebecca, do you want to remind me what that role is?
Sure. I have a kind of catch-all title. I'm an interdisciplinary education director, which means I look for opportunities to connect our U of M campus partners with community partners in order to train folks around disability through an interdisciplinary lens to make sure people are talking and working across their expertise areas so as to improve policy and services for people with disabilities. But welcome everybody to our last session of Project Scope. It's nice to see some familiar faces, but nonetheless, in case some are new, I will provide us a brief introduction to Project Scope for session 8. Project Scope, as you might know, stands for Supporting Children of the Opioid Epidemic. And our goal is to build a community to share knowledge on better supporting families and the children who were born with Neonatal Abstinence Syndrome, or also called Neonatal Opioid Withdrawal Syndrome, NOWS. So while we developed this series of trainings for Minnesota's early childhood providers and interventionists, we also might have guests coming from all disciplines and backgrounds. So we want to welcome everyone who's with us today. And now I'll explain briefly the ECHO model. Do you want to play that, Courtney?
I think everyone has probably seen it at this point.
Okay, so let me just continue on to the next slide.
Yep.
So as you know, ECHO stands for Extension for Community Health Outcomes. We use a hub and spoke model to connect rural and remote practitioners with specialists across the state to discuss cases that would otherwise be typically sent to large or distant healthcare systems. The ECHO model was developed way before we sat down and knew what Zoom was, but the idea was to train folks across rural and remote areas and to build a virtual community so that they could learn together. And the ECHO model emphasizes that everyone is a teacher and everyone is a learner. And for us, we're centering ECHO as a way to democratize healthcare knowledge. Next slide. And the 4 principles are that we use technology to leverage scarce resources. We share best practices to reduce disparities. And we present a case study to apply our learning and to share our expertise with each other. And then we use data to monitor our ECHO outcomes with our web-based database. So that's why we always have you fill out an evaluation post-session. Sorry, I had some loud traffic coming by my house. Okay, so we're in session 8, and allow me to explain the agenda. Next slide. So we're going to introduce Dr. Kurt DeVine. Am I saying your name right, Dr. DeVine?
No, that's perfect.
Oh, perfect. Good. Okay. Dr. DeVine is an assistant medical director at MEND Correctional Care in Little Falls, Minnesota. He has been a full spectrum family medicine physician for more than 26 years. And as a practicing physician in rural Minnesota, he faces many unique challenges caring for patients in the primary care setting. And amid the evolving care delivery models. And all of this demands forward thinking and creative strategies for change. And I don't know if some of you heard him talking about their response to the COVID-19 epidemic, but definitely they have educated nationally on the opioid epidemic. So as opioid use and its attributing issues became increasingly apparent, he became more engaged, involved in the local community task forces to address concerns on opioid use and dependency within the county. So during this time, Dr. DeVine has changed his primary care practice to respond and improve rural access to treatment for opioid use disorder. Through legislative funding and grant procurement, Dr. DeVine and his colleague, whom we heard from earlier, Dr. Heather Bell, they have initiated Minnesota's first ECHO to reduce and monitor opioid prescribing in the rural clinic setting. So that was a kind of awkward introduction, Dr. DeVine, but please fill in any of the details that I may have missed. Welcome. Thanks for coming.
Yeah, I didn't realize you were going to have that. I haven't been watching my email. Then Katie sent, I sent them something. But, the bottom line is that we've been involved in the opioid epidemic since probably 2014. And really all of the grant money that we've gotten has gone to communities that have mirrored what we did in Little Falls by decreasing prescribing and treating opioid use disorder. Actually, Dr. Bell and I both got boarded in addiction after 4 or 5 years of working it. We kind of went back to school and took care of that, and pretty much now do much more addiction. And we actually have an addiction clinic here in Sartell. And really, so much of what we do is just teach and try and convince people that patients with addiction need the same kind of care that we would give any disease, which I think is so important. So yeah, we can move to the talk if you'd like, unless there's something else. So what I'm going to do today is talk a little bit about smaller communities, because where we were in Little Falls, I think there's just so much advantage to being in a smaller community, because again, we talked about this before people got on, how we were able to engage people in our community that were our friends and our neighbors, and to really leverage all those resources to really change an entire system. It's so much easier in a small community, and the impact you can make can just be huge for your patients. And so, although the talk when they had sent this to me was kind of about, well, how does this affect children and infants? I really look at anything we do for the parents who have addiction is what really changes the lives of children, changes the situations that infants being born into families who suffer from addiction. All of these things are intertwined. And so it's really looking at where can we engage patients in our community, get them into our programs, get them the resources they need. So next slide. I have no disclosures. I wish somebody'd pay me for something, but no, never happens. Next slide. So opioid epidemic and rural addiction. Again, we want to support the people with addiction and keep these families together. I think so much of it, for those of you who understand the ACE scores and all the things that happen inside families, we want to break that cycle. We want to bring families back together. And we need to look at those capture points in rural communities where we find these patients, because often before we got involved in Little Falls, people with addiction were coming in all the time and never recognized. And so it's really engaging your emergency rooms, your jails, which is an amazing place to really make a difference. Finding those patients who need prenatal care, and again, primary care clinics, which are seeing patients with addiction, but honestly rarely recognize it, rarely. And really, the biggest part of what we all should do is really, it's that education for rural communities about addiction. Stigma lives everywhere, and I can tell you in rural communities, it is alive and well, and we struggle with it every day with people who just don't understand the real difficulties patients with addiction face when they're trying to get help. And so it's that ability to kind of get the patients to where they need to be and get the referrals. Next slide. So really, our teaching approach has really been treated about addiction, but also you need to, one of the hardest concepts really for rural America and where we lived was this concept of harm reduction too. And so I'm going to touch on that just a little, because I think it's one of those things that, God darn it, the people that you talk to, they just cannot wrap their head around it. And I can tell you the first person I ever talked to about harm reduction was a guy by the name of Ryan Kelly. And I don't know if you've ever seen Ryan talk. Ryan is an internal medicine addiction doctor in the Twin Cities. And many years ago, he was talking about this way before anybody else. And I'll have to admit, when he first started telling me about this, I thought, well, this is just crazy. But it's what we should all be preaching. Next slide. So just in case, next slide, please. Just in case people don't understand harm reduction, I just want to just touch on it. And really, harm reduction is really about those adverse health reactions that people have from their using, the social and economic consequences. And often I think that when I look back at myself 5 or 6 years ago, if you'd have said to me, well, 10 years ago, let's have a needle exchange in Minneapolis, St. Paul, I'd have thought that was crazy, right? That's just the craziest thing anybody could ever say to me. But in my life now, it's the thing I wish we had everywhere, because what we're trying to do is, if patients are using, we at least want them to be safe until we can get them the help they need, until they accept the help or need the help. We want to be there. We want to have that interactions with them when they come into places to get clean supplies and needles. And it's a difficult concept for people to really grasp sometimes. But honestly, I will always argue for those types of services to really decrease the amount of, especially infectious disease. And if we look at the cost of those things on communities and lives and livers, and it's just amazing how much money we spend because we're maybe a little naive to what we should be doing. So next slide. And again, needle exchange. Dr. Bell wrote something pro for needle exchange, and I believe the MMA's one of their journals coming out, and we actually wrote a lot of it driving down the road. And I thought, again, if I look back at myself 10 years ago, I would have just really been against this. But I think education of myself and others has really changed how I think about harm reduction. Next slide. And again, this is all about improving the lives of patients and their families. It's that transmittal diseases, incarceration. I mean, we take care of people that are incarcerated. I can tell you that 40% of them, 50% of them have issues with use disorders, and in my opinion, shouldn't be in jail. They should be in treatment. We're sending them to the wrong places. And when we do work with harm reduction, we have decreased need for child protection because these patients aren't going to jail. They're not having infections. They're not getting sick and being hospitalized. And again, anytime that we can engage patients, we're going to get better prenatal care in those patients who are also previously using. We give them the services they need. We pull them in. We don't push them away. Next slide. And really, one of the biggest things that we have really worked with the rural communities that are part of our program, we have 12 rural communities from all the way from War Road down to Redwood Falls. One of the things we really wanted them to do is take care of patients who are pregnant and needing MAT. Such an area that we could make such a huge impact when you look at how much expense there is in patients who have no prenatal care and come in using fentanyl or heroin. Next slide. And so we were really looking at getting this particular group of patients the care they need early, because we can improve the birth outcomes, right? We have better sized babies, we have less growth restrictions, their placentas are healthier, the babies are born, and they do better. Now, in the old days being 5 years ago, I suppose, methadone has always been the king, but methadone is not something that we can do rurally. So from a standpoint of people out rurally, teaching them how to take care of patients who are pregnant with buprenorphine has been an enormous thing. And I can't remember the number of babies we've had born in our communities. I think we've had 15 on buprenorphine in our program to this point. We have 2 or 3 pregnant right now. And so keeping these patients with their families, in their communities, letting them have babies while they're on buprenorphine is very safe, and it's something that we have just really pushed rurally. Next slide. And again, we have way less withdrawal. When you look at methadone, those babies are typically always going to need morphine. And in fact, in the 10 babies that we delivered in Little Falls before we left, not one of them needed any buprenorphine or needed any kind of any type of morphine or anything else after birth. They all stayed in our hospital. None were transferred. So honestly, this fact that 31% in some of the studies of nows in patients on buprenorphine, that is very high. I don't think any of our communities have seen that. And I can't think of any of the babies born in the 12 communities. I'm sure it's over 50 or 60 babies. None of them have needed any specialty care. So, and it's really safe. I mean, we keep patients on buprenorphine actually who are pregnant in jail right now. I bet we have a half a dozen that we've started on it. So when they are discharged, they're able to go right back to their normal lives. And so buprenorphine really a key for our rural communities to keep these patients healthy, get them the prenatal care. They are much more likely to get their prenatal care and to see their doctor whom they're comfortable with. So next slide. And again, when we look at buprenorphine exposed fetuses, we prefer this way over methadone, although there are certainly patients who become pregnant on methadone. You never change that. These babies just in general look better during the pregnancy. They have a much improved prenatal strip. They have greater heart rate and fetal movement coupling. These babies look great. And this is something that a family doctor with buprenorphine training and some assisting from potentially an addiction doctor if necessary can easily do in rural Minnesota. So it's another way that we keep these families together. We want that baby to be born without child protection. We want the mom to get her prenatal care, what she will get if she's in a good treatment program. Next slide. And what are the barriers? In rural Minnesota, I can tell you when we went to our hospital and said, we're going to start delivering babies on buprenorphine, it was a total, it was chaos. They just didn't know, they had no idea what buprenorphine was. They had no education, a lot of stigma. Everybody thought people were going to stop breathing on buprenorphine. The nurses didn't want to do it. They thought they didn't want those people on their floor. It was just all these things. And so there was a lot of education that goes into helping a community understand that this is a patient that we need to put as a priority to take care of. And that these babies are just like they're just as important as anybody else's baby. And we need to give them the best care as possible. So it certainly takes a lot of work. And again, I would tell you in the 12 communities that are part of our Minnesota Department of Health pilot program, they are having babies out in those communities and having a wonderful experiences with both mom and baby and keeping families together. Next slide. And again, so much of when we did this is we brought people in. We actually brought the University of Minnesota in. We had some people from the neonatal unit come in and talk to our nurses about the babies. Although we never ever had a problem, they felt much more comfortable having some information from people at their level in nursing and doing neonatal stuff so that they could understand that. We spent a lot of time having our social workers involved and our county people involved because we didn't want to keep it a secret that this patient was having a baby who'd previously been using heroin or fentanyl. We wanted child protection to know that they wouldn't need to get involved. I think that made us all feel great. And although we would often notify child protection they're having a baby, and they might stop up once to see them if they were on parole or they had other things, they didn't need to take the babies. The babies went home. And there's a lot of protocols you have to develop to make your nurses comfortable. And we used something called Eat, Sleep, and Console, taught all the nurses how to do this, set up these whole programs to monitor babies. And it was a wonderful program while we were there. Next slide. And again, step one, again, in anything, especially with the pregnancies and taking care of these patients, is really education. Next slide. And not just the staff, but also patients, because patients are maybe sometimes worried about what's going on. I think that, you need to have that team aspect, the physicians, the nurses, the social workers. We even had a lactation consultant involved, because these babies do much better if they're breastfeeding. And so we kind of formed this whole team around this mom and this baby, and while they're in the hospital. So it was actually just a ton of fun. Next slide. And again, you have to set up those protocols, and people have to feel comfortable if they know what to do if something doesn't go right. How to take care of these patients who are on buprenorphine with their pain, lots of different ways, lots of different things our anesthesia was involved in. And again, baby monitoring and transfer protocols. We had a protocol for transfer, never used it. And I don't know that any of our communities have. Next slide. So let's talk a little bit about the other part of your community that you can get involved in that affects the parents of children, and that's your jail. I believe we were the first continuous program in Minnesota to do buprenorphine in a jail in Little Falls. We started many years ago. There had been a couple other ones that had tried it. Nobody kept going. We put buprenorphine in our jail, and it has changed things dramatically. Next slide. And in fact, it was a barrier. But I think those of you who are in rural communities understand that if you have connections to your jail, and we have probably 12 or 13 jails, 12 jails in our community program as well, that are also ones that I work in and other people in our company work in, that now do buprenorphine in jails, because we want to get these patients where they are, take care of them, get them on medications, and connect them back to their communities. This is how they get their children back. This is how they get their jobs back. This is how we really work hard at making sure that these patients have those connections made before they leave jail. That's extremely important. Next slide. In fact, we have another grant that's coming through the Minnesota Department of Health to do this in more jails, which is pretty exciting, because this is what has happened in our community prior to us showing up with buprenorphine. It was the same old thing. People went into jail, they stayed in jail, they got released, they used again, and some of them died and some of them lived, and then it just started all over again. We've lost 5 of our previous patients in the last 4 months in Little Falls, and some of them in and out of jail that didn't stick with us. And so, we doubled our efforts really to try and make sure that we connect these patients as soon as they come in. It's just so critical to start them on the buprenorphine in the jail, keep them on the medication, and then get them connected to a community program. And actually, I was on the phone just before this call, connecting a lady down in the Twin Cities who was in jail to a program. We were actually going to do telemed visit to make sure that she didn't run out of medicines, to get her to a program that we consider reputable. Next slide. And again, it's hard to teach some of the people in the jails and correctional officers. My father was a state patrolman. Drugs, boy, it was good and bad. It took a long time, I think, for my father to understand addiction. And I think until I really started to do this kind of work, I think it's really a stigmatized area. It's amazing how many places we go now where the correctional officers and the policemen are heavily involved in this work now. It's changed, I think, completely. And sure, there's still some stigma, but it's really sitting down and teaching this group. And we've had many talks with police and correctional officers about addiction as a disease and how we treat it. And our goal really to get people back to their families and back to their work. Next slide. Because again, what we want now is we want to get them in the jail on their medication, again, released to those programs, and we want them on programs for as long as possible. The actual rate of retention for most Suboxone programs is roughly 70%. It's probably 75, 80% for methadone. But again, with Suboxone, the beauty of Suboxone is often you're not being seen only once a month, whereas obviously if you're doing methadone and you're there every day, pretty tough to keep a job. 70% of our group actually works. And we have actually retired patients who have been retired for quite some time. We have grandmas. We have really a variable group in our program for Suboxone. Next slide. The emergency room is another place in a small community that you want to be. You want your physicians to recognize who has an addiction issue and not think that their nausea and vomiting and diarrhea is the flu, which is a very common problem. It was horrible in our ER. We'd have patients go in there with abdominal pain and all kinds of withdrawal symptoms, and they'd get a couple Percocet for their abdominal pain, and boy, they were perfect when they left. We've had a lot of patients tell us that they'd go there and complain about abdominal pain, and they'd get a couple pills to go home with, and that's how they'd stay out of withdrawal. Next slide. So engaging your emergency room is really critical because, again, we want to capture the patients where they are. It's that whole nursing buy-in, again, stigma. Did I work in ERs when I was less educated? Yes, I did. Did I see this group as somebody I wanted to see all day long? I did not. I don't think I was a great doctor a decade ago. I think I was uneducated. I think I clearly had stigma. And I think that it's that education that turns us all around. Okay, next slide. Often the ER feels like they're just taking up their beds and they don't have time for them. But the same thing happens in the ER that happens in the jail. And these patients go in and out and in and out. And there's actually very good data that shows if you have a patient that goes to an ER 3 or 4 times in a year, their risk of death is like 25% or 30%. It's high. I don't store these little numbers away, but I can just tell you that if you have somebody that's overdosed multiple times and been in the ER, their risk of death is super high. Next slide. And again, the funny thing, and this is just one of those funny kind of things that sometimes you come across, in the old days, car accidents were much more common than overdose deaths, as far as car accident deaths. But yet every ER doctor has to have ATLS, they have to have ACLS, they have to have all these things so they can take care of a trauma. But in fact, now more people die of overdose deaths, but nobody has to give anybody buprenorphine in the jail. You don't have to do anything. You don't have to be waivered. You don't have to have an interest in that, despite the fact this is one of the highest risk groups you're going to see coming through your ER. Now, has some of that changed over the past year or two? It has, but it is very hit and miss. Actually, I just had a phone call with one of our communities, and one of their doctors, who's been just fabulous, a family doctor who does buprenorphine, is sitting down with their ER doctors again to talk to them about making sure that they're treating these patients. And so the work, it really continues. Next slide. And I already talked about that. One more slide. And this is our protocol, which I won't bore you with, but I mean, we set up these protocols to have on their wall. So if somebody came in, they knew exactly what they could do. At the bottom of those protocols are actually our phone numbers. And so we would have them call us. And even though I'm not at Little Falls anymore, they still call me. And I think that's fine. We want to get these patients somewhere where they can get taken care of. And sometimes to make it very simple for the ER doctor just to say, hey, here's the deal. Here's how you can do it. Call me if you don't understand it. Next slide. So in summary, I think rural communities are just uniquely positioned, not only to identify these patients, but also to offer treatment to patients with addiction, and understanding that the treatment can start right where they are, whether it's jail, whether it's OB, whether it's the ER. You don't get anywhere unless you start the treatment. And again, identification and treatment of patients with addiction when they present for any of these services will end in the decrease of overdose deaths and help families rebuild these relationships. It gets people back to work. It's good for us all, for all of us combined. So I noticed there was a couple of chats or something. It says, can you talk more about the formal process or protocol for supporting mothers who are transitioning back into the community programs from jails? Yeah, and let me tell you, I believe that Dr. Bell and I were the first people to do a microdosing in a jail for buprenorphine. What happened when we transitioned to doing correctional care was fentanyl became extremely popular. And fentanyl, the old days being 6 months ago, okay, in the old days, when people would come in heroin withdrawal, almost nobody was giving anybody buprenorphine. They just let them be sick and then they get better. But as you all know, fentanyl is much stronger than heroin many, many times. And so the withdrawal symptoms that we're getting now with patients in jails are horrendous. And these patients end up in jail and they end up in the ER because they're so sick. Well, then what happened was literally we weren't in this job for weeks and we got a pregnant woman withdrawing from fentanyl, which was a whole new thing. Imagine trying to start somebody on buprenorphine from 50 or 75 miles away at 10 o'clock at night. You need to microdose them. You need to do a very special kind of starting the buprenorphine so that you don't put somebody into precipitated withdrawal and make them sicker. And so we do a lot of work, and I've been doing it today with 2 patients who are pregnant in jail. We do a ton of work in making sure that as soon as they come in, we get them on the buprenorphine. If they are at all sick or ill, we send them to the ER, we get them fluids, we do those things. We start them on the buprenorphine in jail. We very quickly set them up with OB care, no matter how long we think we're going to be there. So we make that connection right away, and we make it with somebody who also does OB care and understands buprenorphine and understands addiction to a degree. But then we also set them up with somebody who does buprenorphine, such as a family doctor or an addiction doctor in their area. Sadly, the only 2 addiction doctors north of the Twin Cities, I think, are Dr. Bell and myself. So that's been a little bit tough. But we have a lot of friends who do buprenorphine in rural Minnesota, and many of them are very comfortable with the pregnancy. So it is, there's a lot of phone calls. This is something that I think MendCare maybe didn't do before, but we've made this a priority to make sure that those moms and babies are safe. So yeah, thank you for that question. It's a lot of work, and I spent a lot of work on the phone today just for one patient, trying to make sure that she didn't leave and not have a connection. So do we work with oh, this is going to be a tough one. Do we work with teenage under 18 mothers, and how long can babies stay with the mothers post-birth in correctional settings? Yeah, now I'm not really sure how long moms can stay post-birth in correctional settings. I've not had that particular situation. Now, teenage under 18 moms, interestingly, we have 2 or 3 juvenile centers, and we now have a pregnant young lady in a juvenile center who's on buprenorphine. Now, the rules are a little bit different. Like on the outside, I mean, honestly, we've had patients under the age of 18. A lot of the family doctors feel uncomfortable with it. The addiction doctors have discussions like this all the time. As you know, if you are pregnant and you're over the age of 16, you're considered emancipated, right? You can make your own adult decisions. And it is very similar, but slightly grayer for addiction, okay? And some of you out there who, I don't know if you have social workers on here, but the social workers may know more than I do. But when we've had to deal with young people with addiction, interestingly, I can send somebody to treatment who is 17 years old, but they can sign themselves out. And so it can be a little bit tricky. And so a lot of working with that age group is really communication, and it's really having the discussions like they're an adult. You don't tell anybody under the age of 18 what to do. You tell them what their options are. And it's a lot different kind of conversation. You gotta be very careful not to be their mom or dad. That's what I've learned. You're their doctor, you're not their mom or dad. Here's what we can do for you. So, but yeah, that's a whole different can of worms. Any other questions?
Dr. DeVine, I have a question. This is Jennifer Hall Landy from the University of Minnesota. Thank you so much for a great presentation. I really enjoyed it. And to answer your question, there are social workers on the Zoom. We're predominantly early intervention providers. So most of us work with families, birth through 5. Some are social workers, some are teachers. A lot of early intervention providers. But I have a question. I ask it every time. But since you work with families and you have such a valuable lens, if you could give us any advice, one piece of advice in terms of how to partner with these families, how to work best with these families. I know you bring in a unique perspective. What would you tell us?
Yeah, it's funny because, when I was still doing family practice, and who knows, maybe I'll do it again at some point, but when I was doing family practice and addiction, often I would, and I can tell you, I had one family where I took care of both mom and dad who were in recovery, and they had 2 children, and they're pregnant again right now, which is sad for me. But it's, I think the biggest part really of taking care of anybody in recovery and their families is just to be very frank and just to have really frank conversations. It's that whole thing, you don't overpromise, right? Anything. I think if there's one thing I could teach everybody about addiction is the one important thing, and I say this to patients all the time, because the minute they have a little bit of a lapse and they have a problem, they're so down on themselves. But right from the get-go, I remind them that addiction is a chronic relapsing disease. And I say that to them all the time, because I want people to understand when they have a bad day and something doesn't go right, that is such a small part of their life. And we just get right back on track and we go again, because that's how you keep the families together. If you have somebody and they have a little lapse and they just totally wig out and they leave the family and they feel so guilty and terrible. But I think everybody has to understand that it's chronic relapsing disease. And I say this to spouses all the time who do not have addiction issues. I say you have to understand this is a chronic relapsing disease. None of us want that. But more often than not, over a period of 5 years, you're going to have a little thing, just like you'd have a flare of psoriasis. Sometimes it happens. And we just have to regroup and we talk about it and we move on. You know, I say those words everywhere I go, whenever I speak. You know, this is a chronic relapsing disease, period. Don't expect these people will be perfect. Because, and I'll tell you, in the jail system, I've had nurses say all the time, or COs say, yeah, they just keep coming back. You know, it's like, yeah, well, addiction is a chronic relapsing disease. You know, we expect that they're going to have troubles. Frankly, I don't think they should be in jail because they have a chronic relapsing disease, but that's what it is. So I think it's important to remember.
Yeah. Thank you. Thank you, Dr. DeVine. That's a really helpful way to look at it. I think it's a helpful frame for many things, even parenting. We're always trying to do better. Sometimes we take a step back. So yeah.
Well, the key with parenting is just don't do anything, because they'll live and they'll do it better on their own than what we could tell them to do it. Right. So that's why my kids were, you know, always hurt. I'd say, well, see how this works out. You know?
Thank you.
You bet. That was kind of a long answer to a short question. Anything
Very
else?
helpful.
It's very a good answer. I'm going to open it up to everybody here. Does anyone else have any questions they can unmute or put in chat? And we're ahead of time, so we do have time for questions or comments.
I didn't even look at my watch. I don't know how we did there, but it was close.
I have kind of a broader question of and thinking about also other early intervention systems is when we are in more, you know, the Twin Cities area where it's less of that informality of picking up the phone and being able to call somebody and get a live person on the other end, and there's these kind of more walls up between some of these systems. Are there strategies that your team has employed or that you've seen work with other groups to get some of that same feel?
You know, I think that in some of the bigger places, and some of my friends who are in bigger areas, you know, they develop their own little kind of area like that, right? They have their normal patterns of referral. They develop kind of a team that everybody knows each other and everybody's comfortable with each other. And I think it's basically like its own little town in a way. And it may not involve the police, but it involves the hospital and it involves the social workers, and they have their own kind of little kind of go-to group. And I think it's always really helpful. And I think in a rural community, it's always helpful when I say to patients, they'll say, well, I saw so-and-so, such a counselor, and they said, I should come see you. I say, oh, I love that guy. He's such a nice guy. You know, we know each other, right? And I think that makes patients much more comfortable. And when I refer people to somebody, I say, I want you to go see this mental health person. I love them. They're a close friend. They do a great job. You know, they want to stay inside your system, right? They trust you, and you need to send them to the people that you trust. And I think that's what gives them comfort. And they don't want somebody to judge them. They don't want somebody who's going to second guess them, or, you know, and so it's important that you build that group around you, that, you know, when you send them there, they're not going to get that, right? I mean, when I send them to somebody, they're not going to get that. I trust the people that I use for my referrals. So somebody asked, where else besides jails and hospitals can some of these issues be addressed in the community? And, you know, jails is not the police, okay? The police are a whole separate thing. And I'll tell you that in our community, it was not uncommon, and it's still not uncommon for me to get a phone call from the police and they want to send somebody to me today, like right now. When I was still in Little Falls, they would bring them to the clinic and walk them in. And we had multiple patients in withdrawal that they were at a drug bust, they got a bunch of sick people, and they would bring them to our clinic, call us and say, can we drop somebody off? He wants to see you right now. And so I think that the police themselves, if they know that you're going to take care of this patient, they drop off right now. And I have never said no. I mean, if they call and they say, can I bring them now? Yeah, it's Friday, it's 4 o'clock, but bring them in. You know, what are we going to do? And I think that that's really an important thing. The ambulance groups, right? We had a very good relationship with them, and because we wanted to know who overdosed. That was important to us. If they had an overdose, and they gave them our cards, okay, the police carried cards from us where they would hand them, and they have them now. Now they have our new address, but the police in Little Falls have our cards and they hand them out at the scenes of overdoses. And that's the way to get these patients to come see you and find you. So yeah, there's lots of other places. But I think that in a community our size, I can't tell you how many random people would call us and say, I heard you do this. My son-in-law is in town, he's sick, can he come see you? You know, it could be anybody. So it's just getting the word out. We put flyers in bars. We had flyers in all kinds of places. So the bars are where there's a lot of addiction, and alcohol and heroin actually run together a lot. So we put a lot of flyers in there. I think that's all the places I can think of. Those are the kind of ones we hit.
Yeah, you're making me think of how some of the early intervention work you do, Jen, on thinking of creative ways to reach families, on learning the signs of early development. It's very similar. You have to think where people are
Yeah.
and share that information.
I can't tell you how many people in bars ripped our numbers off and ended up coming in. And, you know, we see people for alcohol too. So, I mean, it was like, but yeah, we put those in bars and in bathrooms in bars. So not only could you find a lawyer in a bathroom in a bar, you could also find an addiction doctor. Yeah. All those injured in an accident signs by the bathrooms. So. All right, anything else?
Well, thank you. Thank you so much for coming today. We appreciate it. It was a very useful presentation. I learned from you. So, and I'm sure all of us have. Thank you for your work that you're doing in the communities. And we hope to have you back.
All right. Well, thank you so much. I'm going to have to get back to work. So thanks again for everybody listening. All right. If there's ever any way we can help you, please reach out to us. We always got some idea. So
Yeah.
That's excellent.
Take care, everybody.
Thanks so much.
Thank you so much. Well, that was an interesting presentation. I hope you all learned from it as I did. The next step is to move on to our case study. And you've met her before. Dr. Simasek, Jessica Simasek, has a PhD in educational psychology with a focus on special education. She is the director of the Tele Outreach Center, and she's also a researcher at the Institute on Community Integration at the University of Minnesota, which is also the sponsor for this Minnesota Project Scope series. Dr. Simasek specializes in supporting children with behavioral needs and complex communication needs in both home and school-based settings. She researches ways to use telehealth technology to improve access to high-quality assessment intervention and supports for children and their families. Dr. Simasek, thanks for coming and running our case study today.
Thanks for having me. Nice to see everyone. And we'll walk through the case study in that same process that we've been using. If you've been here in the previous weeks, I'll just briefly outline it. I'll take a few minutes to walk us through this example case, and then I'll pause at the end where you can ask any clarifying questions that you may have either via chat, or we're such a small group, we encourage you to come off of mute if you're comfortable doing so. And then we'll have 3 guiding questions. You're welcome to expand beyond those, but to guide discussions when we do break into small groups, which I'm guessing will only be a couple given the size of our group today. You can have those great discussions. Everyone's been coming back with just such rich information on resources and ideas for families that might be in a kind of similar situation to the case studies that we talk through. So I'll walk us through this one. This is an example that highlights the needs and the strengths of this family. It's a 40-month-old child, and he is home with his biological mother. And as you'll see in the upcoming slides, she's been successful in recovery and is in ongoing recovery for the past 3 years. Some of the topic areas that we'll touch on is prenatal exposure to opioids and to marijuana, developmental delay or potential developmental delay, and then also at the same time supporting this child, supporting the mother through her continued recovery so that she remains really healthy for the well-being of the child. Next slide. Just a little bit of additional information. So this child's living with his mother. There's just one child in the home. He doesn't have any siblings there. He has experienced prenatal exposure to methamphetamine and marijuana. And he was in the NICU as a baby, but he's now healthy. He's had normal development and had some follow-up and everything has been going okay, aside from some difficulties around speech language. So as you'll see at the bottom, he is receiving speech language services from a clinic. His mother, as I said before, has been doing well, and she's restarting some part-time college courses in the coming fall, and so wants to make sure that she continues to do well with this additional change and good stressor, but a stressor. He and she both have support from the maternal grandparents who definitely want to help out in any way that they can to help make her successful and encourage and keep the child really healthy and happy. One theme that will come up in this case when we get to one of the next slides is that the child does well at home. So he's doing great. He has a great relationship with mom, has a great relationship with grandparents, but he's in a Montessori preschool and experiencing a few challenges there. So let's highlight the strengths of the situation first. There's probably many more in addition to these, but some of the strengths is he's got this great family that's very invested in him. Mother's doing really well, very successful in her recovery program. She's very involved in the services he does receive. He is very successful at home, so she does not see that same behavior that they're talking about at the school happen in the home. Now, some of the barriers are there's some indicators that he's at risk of being asked to leave this Montessori childcare preschool setting. Due to some aggressive behaviors that are occurring. And then his mom's also just concerned about making sure he's ready for kindergarten. Next slide. So those primary concerns again are his speech and language development. He is speaking in words and gestures, but not yet using full sentences. And he can become frustrated when he's not understood or his needs aren't being met. As I talked about, there's some aggressive behavior that's occurring towards peers and adults at school, but it's only occurring at school. So mom will describe this like he's kind of this kid that they're describing is a different kid. This isn't the child I see at home. So that's difficult because it kind of leaves her at a loss for how to support him when he does just fine. Some of the behaviors the school is concerned about is hitting peers, running away from adults, having poor transitions between activities such as leaving the park and going back into the classroom. And then again, the overall wanting him to be ready for kindergarten. All right, next slide. All right, so this will be our last slide, and I'll pause for some clarifying questions before breakout rooms. Of course, you're welcome to go beyond these questions, but given our limited time, you're always doing great at getting these answered. One theme or one question that all of you as early intervention providers have maybe heard before is how can we kind of support and communicate with this family and with other families in this kind of a situation when there's that kind of mismatch between challenging behavior is occurring in one setting or the other, but it's not occurring in both. So not that the mom doesn't want to support this child, but she doesn't really understand what's going on because she's not seeing him do these things at home. And we all know that that can be vice versa too in different settings. So that's one question to kind of think about. How do you approach that? How would you communicate that with the mom and in the support plan? Given kind of limited socialization opportunities coming out of COVID, he doesn't have other siblings, would there be some strategies to help the child socialize a little better with peers? And then the grandparents, they really want to help. They want to be there for mom. They want to be there for this child and her continued well-being. So what would be some things that the grandparents, it's awesome to see this, right? They're there, they want to help, tell us what to do. So what could we advise them on some things that maybe they could help with? I see some things in the chat, but they might be from before. Is there any clarifying questions that anyone wanted to ask before we move into breakout rooms?
Jessica, I just posted details from the slides, so we have them.
Oh, I'm so glad you did that. I know you go to the room and then you're like, oh, the information isn't there. That was a good idea.
And I think we can just go ahead and stay in the main room because we only have a few people.
We can do a group process.
Yep, if we want to just go ahead and start discussing.
Everyone's kind of coming on and thinking through these questions. I will say that first question really speaks to me for someone who does support a lot of children who have behavioral kinds of needs is this is very common that either we're seeing challenging behavior at home, but we're not seeing it at school, or we're seeing it at school, but we're not seeing it at home, and how to kind of help the communication between both groups that are there to support that child is definitely a theme I tend to see a lot.
Yeah, Jessica, I would agree. In my time as a school psychologist, it was always easier when there was agreement, but it was not uncommon to see differences across settings.
Yeah, I think one thing that I would ask for, and I don't know if you all know better at this age, but a functional behavioral assessment to see what the triggers are in the environment perhaps that are occurring for the aggression. There could be bullying either by peers, at that very young age, or it could be some staff aren't working well with the child or using an approach that's not helpful or positive. I'm just thinking out loud. Anybody else?
Oh, I like that, Rebecca. I think that when we suggest how do we try to isolate the function of the behavior, it gives us a lot of information about what's happening, and we can make assumptions all day long about why it occurs here and not there. But unless we really take a hard look at how the routines are going and what are the antecedents and what are some things that might be happening. And I was sort of in and out a little bit. My attention's a little divided today, but I was thinking if this child is receiving speech services from the school, they can conduct a functional behavior assessment as part of that plan. It used to be it could stand alone. Then I think now the criteria are that a full-blown re-eval needs to happen. But boy, if he's under threat of being kicked out, that tells me there are some needs in that setting. But that's where that developmental delay, if he's 1.5 down, it's not necessarily EBD criteria. You're just looking at a need that is discrepant enough from other kids in this young age where he may meet the eligibility criteria for ECSE services or developmental delay versus just the speech and language services. So also the communication piece obviously is a factor.
I know there's a big push this year too for kids that are under SLI, and it's not just speech, and that services can be identified if they're qualifying under articulation, and from the evaluation they had a need in another area, services can still be provided in that area. So we just need to remember that too.
I'm also wondering on the transitions piece. So the child is struggling at transitions. So investigating that a little bit more seems smart. there are obvious, in my field, obviously I think about autism as a possibility when transitions are very difficult, knowing that's not alone, why people struggle with transition, but maybe an evaluation is needed if that presents itself dramatically in the school setting. Because often at home, people kind of shape the home setting to be exactly smooth based on avoiding meltdowns. So.
Yeah, I think that all the recommendations have been great, and echoing all of them, of course. But that combined piece of when you're the only child home, then you maybe aren't having to share your toys, or you can kind of transition around what works for kind of the flow of your family. And then also that kind of coming from the communication perspective of parents are, mom and grandparents are very familiar listeners, and so his gestures and words might be able to be honored more frequently just because they understand him better. It's more intelligible to them than more novel listeners in a school. So I think that making sure that even if he is getting some speech and language, that there's some maybe opportunity to model, or sometimes we'll do, like a little inventory or cheat sheet of them. He says cookies, he wants the Oreo cookies and not the other ones. Or if you go to the fridge, that means probably want the juice out of the fridge. Just ways to kind of support that he's being understood in both environments. And if there isn't some form of augmentative or alternative communication, could there be some maybe pictures to kind of help augment that as he's still learning language and speaking?
Yeah. Well, one thing I would add, Jessica, and I appreciate all of these suggestions, and it's a little bit of a different take on it, but sometimes when we did have really different reports across settings, sometimes I think it was an issue of trust of the team. Sometimes I think parents were sometimes protecting, I'm nervous about you diagnosing my child or what you'll think. Not always, but sometimes I think it was an opportunity of how do we build trust with this family so we can talk together and communicate. What are we seeing? What are our options to get the family support, maybe in a way that they don't feel as stigmatizing? I mean, I think sometimes it opened up for a discussion about what expectations were. I mean, can you work on building that relationship and trust a little more?
Yeah, I like that suggestion a lot. I think you oftentimes find with these moms where they go right to a shame place around, I caused this. This is why my son is acting this way. This is why he can't get along in other places. And it really compounds that mom's ability to kind of pull away from that history identifying her. And so I appreciate you saying that, Jennifer. And I also think about the mental health supports and resources that are available to child cares now. There's a whole network of therapists that can be tapped as a mental health resource to a child care. I don't think any child care at this point should be talking about kicking a kid out for quote unquote challenging behavior unless some of those resources are tapped. But I know that they're consultative and paid for, so that can be kind of tricky. But honestly, what are we saying to a family when we say we can't manage this 4-year-old's behavior in our setting? So I think that's really an important piece, and also is affirming to the mom that there's help needed and we can tap help to address this.
Absolutely. Susan, that's such a good point. And I loved what you said about let's take the shame out of it. This isn't about shaming and blaming. This isn't about kicking a child out. It's how do we create an environment where the family feels comfortable and the child feels safe. Yeah. Knowing that many of these situations are complex. Michaela.
You gave a great point about Montessori also being a very self-motivated, self-starter learning environment, and not every kid works well with that and may need more structure. So I thought that was a really good point.
That's a great point, Jean. I've seen that for sure.
And then Michaela, Do you want to talk more about that center? If you don't mind.
I'm sure it's the Center for Inclusive Childcare. They work with
Your audio is difficult to understand.
Michaela, do you want to chat in, Michaela? I can read it if you chat it in. I'd be happy to read it, Rebecca, if she wants to chat in.
We could. I'm sorry. There was a weird echo. It might have been just your microphone, or was it just me, or did others hear a strange echo?
Michaela said the Center for Inclusive Childcare works with all licensed programs throughout the state.
Oh, okay.
And they provide mental health services at no cost to programs. And I agree with Michaela, they do wonderful work.
Yeah, and I just wonder how well versed are childcare providers about this resource? Is it pretty common amongst our experts in the room?
Well, Michaela says they have funding available, so it is typically free to programs via phone and in person if available.
Yeah, so maybe we can find the link for that, Courtney, and share it out with our send out. That would be great.
Yep, I can do that.
And Michaela, in my work with them, I have found them to be extremely responsive and receptive to helping out. So thank you for bringing them up.
Yep, thank you. Sorry, I couldn't understand your when you unmuted. What about the second question? I'm just curious if anyone has ideas for helping the child socialize with peers.
I think, you know, I know we've talked about ECFE before, probably multiple times at these, but knowing that grandparents could take him to ECFE too. So if they're looking for ways to be involved, but maybe, you know, want a little more structure or a little more, you know, support instead of just kind of showing up at the playground and hoping there's other kids there, maybe signing up for ECFE, but also welcoming the grandparents to kind of attend with him. Just one thought.
I can add to the conversation. I didn't earlier because I was waiting to hear, but I have spent 20 years working as a Montessori guide. So I taught in 3 to 5 classroom for that long. And oftentimes what it is the environment is very different than what people are used to. And secondly is maybe the team coming out to support the child could learn or do a little research on what is involved in a Montessori environment before decisions are made. And oftentimes there's not enough support for the guides to help children in this situation, or the support that comes from the schools doesn't really help the environment, or they just come in and tell the teacher what to do, but it doesn't work in that environment. So what I'm getting at is communication, learning from each other, having somebody who's knowledgeable, or at least research in Montessori. And the Montessori environments are social. I mean, there's social opportunities day in and day out. And if the right team can support the team at school, a lot could really happen.
Brenda, that's a great point. Can I ask you a question?
Sure.
When you've seen it work well, when you've seen a support come in a Montessori environment and work well, what have sort of been the key ingredients of that? It sounds like understanding the Montessori model a little better. I'm just trying to think of our early intervention providers here that might get put in that situation to go into a Montessori, and what do you think helps that be more successful?
To be honest, when I was teaching and before I moved to ECSE, we did not get support from the schools. When we did get support in, a lot of it was lack of knowledge. We did not have the knowledge in the Montessori school to have people come in and support us. Does that make sense? So like, it really has to be teaching the Montessori school what you can do and how you can help them in their environment, and not you coming in and taking the child out and working with them. Does that make sense?
Yeah, it does, Brenda. Thank you. I think that's a really helpful point, because I have seen kids thrive in that environment, but you're
Yeah.
right. The support's going to be appropriate and they need to understand a Montessori model.
Yes. Yeah.
Thank you so much for sharing
Mhm.
that.
Mhm.
I was kind of going between question 2 and 3, but are there other thoughts on either socialization opportunities? If this is a preschool that's nearby and they have some, connection with any of the families there, also seeing if maybe one of the students isn't, could meet outside of school and have a play date or go to the park or something to have a little bit of practice outside of the larger context, or exposures. One other thought for number 2. And then we can also, if we don't have more for 2, we can also start to answer 3.
Well, I'm also thinking for 2 is the positive supports modeling. So maybe the staff might appreciate some positive supports instruction on how to positively model when, how they explain in the socialization conflict, like how do they model that with the child versus saying, stay away from X because you're doing bad things, but like, how can they positively, communicate with the child on the expectations for behavior in a way that isn't stigmatizing or making them feel like they're a bad child. So I don't know what resources there are, but Jessica probably does.
Yeah, I mean, they definitely, we've had a lot of different providers join some positive behavior support trainings that we give with DHS. And those are, they're intended for organizations that want to incorporate positive behavior support strategies, which of course schools are very familiar with, the pyramid model, a lot of the same kinds of concepts. So we've had, I can't think if we've had any Montessori providers join that, but we definitely have had like Head Start join or other early intervention groups join. And there's a lot of resource. I mean, MDE has a lot of resources on things like the pyramid model and stuff that maybe a private childcare could, that maybe there'd be some things online that they could access or attend. And I mean, again, I've supported some kids in Montessori environments, and lots of times a nice thing is that they might have like carnival days or like family engagement days, which again could be a nice way to maybe meet a couple other families. Not that necessarily the team could recommend you have to find another child to go work with, but if those things can kind of organically happen through some of these like family engagement events that are hosted, if they have events like that, encouraging mom or grandparents to take the child to those. Yeah.
Mm-hmm.
And the classes, I think, is a great idea. Just those, formal community classes. Be a great way to meet kids that live nearby, make relationships, help form relationships with the family so that they can then set up, opportunities to play with friends.
Dr. Simasek, I'm about to make an obvious point, but it just struck me as in so many of these case studies, the grandparents are taking on a caregiving role, a supportive role. And I know from experience, sometimes grandparents feel, they love their grandchildren, they want to support them. They also feel like maybe an ECFE class with other parents that are much younger from a different generation might be hard. It just, to me, an important component of any of these interventions, or maybe some grandparent specific interventions. I mean, obviously I know, I live in Minneapolis, and Minneapolis is very large and it has lots of different permutations of ECFE classes. And I think they had one for grandparents. But I mean, I know that may not be an option in rural areas, but it just makes me think if you were doing an intervention with this population, it would be important to address that. Yeah, kinship, grandparent support groups.
Yep. I'm thinking with Lutheran Social Services, we actually have a combined class in St. Paul, and it's a kinship class. And a lot of those kinship providers actually are caring full-time for the children, but some of them certainly have their adult children at home as well. And, multi-generational homes, but providing more than just childcare for these kids. They're really providing a parenting role to the children as the adult caregivers are really trying to work on these things that have been so cumbersome and hard in their lives. And so you're absolutely right. Like, I think about that for our younger moms too. We have some, we have a teen moms class at our pregnant and parenting teen school, but if the kids aren't enrolled in that school, then they don't have access to that ECFE class. And I can't just send them to a class that has moms who are, late 20s up to 40 something, because they're teenagers or they're, young 20s, and they just don't feel the connect with those other moms. And so you're right, the iterations, especially the further out you go, the resources are fewer. But if we're talking about families, moms who have been dealing with addiction, an ECFE class around that would be really important too, I think. And maybe even a multi-generational class where they break out into subgroups with the grandparents and the parents. I have all kinds of ideas, just no money to make it happen.
No, well, that's where it starts. You need to apply for a grant. We're always applying for grants. No, but you do think of that. There are unique needs. I mean, there's dynamics between, the mom or the parent and her parent, so you think of that, you would want to address some really unique aspects of that. Go ahead, Rebecca. I don't want to steal the.
Oh, no, not at all. I just was chatting that if anyone else wanted to add anything so that we can have a robust recommendation that they could use chat or unmute. So.
And I've just informally been compiling what I've seen in the chat and what we've been verbally saying in a document as well. But I think there's plenty of space to add to it. All right, are we at summary time, Courtney? Are you prompting me for summary time? Because I can do summary time.
I think so. I mean,
since we were all part of the same group, everyone got to really hear what the recommendations were. So I think we had that chance to summarize, but
and I'll send it out in the email too.
Yeah. Thanks, everyone.
Okay, great. I guess I'll move on to, looks like we might end early today. Not a bad thing for our last session together. So I'd just like to thank Jessica or Dr. Simasek again for helping us with our case study. And thank you to you all for participating and providing your input. It's not too late to put in chat if you also have additional input you wish to share. If you just think of something additionally. We will provide a case recommendation document in an email to everyone who attended today and to everyone who registered as well, along with the Zoom recording. And I also want to thank again, although he's not here, Dr. Kurt DeVine for sharing his expertise with us. And I hope that everyone benefited from the lesson or I want to say the Zoom, but the project scope. Okay, next slide is up. All right. As you know, you'll get an email with a link to fill out a REDCap survey, and your certificate of participation will be sent by a later email after you complete that REDCap survey. We use the survey to improve. As we mentioned before, we're planning to have another derivation of this 8-session topic, 7 to 8 sessions on a similar topic. We may have the same speakers, but we will likely have additional speakers. So there may be new sessions that you haven't attended that you might wish to attend. So keep that in mind and keep your eye open for the announcement on the dates. Also in your red cap survey, if you wanted any additional note box to add like days of the week or times that work best for you, we'll keep that in consideration as well. All right. We look forward to hopefully seeing you again. We hope that your experience in the 8th session project scope was useful to you, and that you've built a network, and feel free to reach out to us if we can support you in your work with children who have been impacted by the opioid epidemic. And we look forward to learning together again this fall.
Yeah.
So thank you, everybody.
Thank you, Rebecca. Can I add one thing too?
Yes, please do.
I just wanted to thank everyone as well. Since we've been sharing the facilitation role, you feel connected to the group, getting to see everybody the same time these past 8 weeks. But please let us know if there's additional topics. All of you are welcome to join us again if you want. And we hope we can offer some new topics as well. But please feel free to reach out, put that in your red cap survey. We'd love for you to join us again, and tell your colleagues as well, because the more the merrier. Yes.
Yes. And if you know of any amazing speakers that you think we should reach out to and contact, please also include that. Either shoot us an email or include that in your red cap survey so that we can develop a strong session for everybody this fall. But it's been a pleasure getting to know our repeat folks, and we hope to see you again. Thanks so much.
Thank you, everyone.